Hello everyone, I'm Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This section has to do with risk out criteria for your practice. A legal disclaimer we put at the beginning of all of our presentations. This is general and educational use only, not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. So this topic is really important when I talk with consulting clients all the time about not everybody's a good candidate for a home birth, not everybody's a good candidate for a midwife. What is your risk out criteria? What do you have for your scope of practice of what you can do independently, what you collaborate on, what you transfer out? And many midwives just don't have something written down or don't have a hard criteria very detailed of what they risk out. They individualize it and make social decisions based on they had a bad birth trauma, so I'm going to stretch my envelope for this lady compared to someone else because that emotion is getting involved versus you have a guideline to reference and you're following it. So it's a really important thing. It helps you to understand treatment plans. When are they a good candidate initially to be part of a midwife? When throughout the care do they need to be seeing a doctor? Should deliver in the hospital? Should be transferring care? It really helps you with risk factors too. It's not just about can they stay with me and when they can't. If they've had a history of anemia, that's a risk factor. That's criteria we want to be keeping a closer eye on for extra CBCs, evaluating things, maybe considering starting iron. So you want to identify risk factors and then you want to determine, does it risk out of my care? Is this something I can do? Can I take care of them? Can I manage this? Is it still make them a good candidate for the services I offer? And if it doesn't, what is the protocol to get them somewhere else versus saying, I'm sorry, I can't take care of you. Google search who can be a doctor. Like, it's really important for us to have collaborating relationships and built up for pediatricians, obstetricians, family practice. And if you're doing well woman care and gynecological and primary care services, you want to have it with other specialists, dermatologists, GI doctors, oncologists, depending on the scope you serve. But most of the people taking these courses is going to be midwives and prenatal visits, birth, postpartum. And too many times, part of the lawsuits, part about outcomes, they weren't screened and risked out appropriately for their medical conditions, for their needs, because we want everybody to have a normal birth. We want everybody to have a great outcome. And sometimes we push the envelope based on risk factors because we want everybody to be normal. So you need to definitely determine, we want to prevent injury, we want to help improve the quality, have legal defense and a reference point. So let's get back to the basics, like what exactly is risk criteria? So the term references making a judgment and a decision based on how much risk is involved in a medical condition, a management decision, a comorbidity, a social history. Maybe they've had 3 prior C-sections. They're probably not a good person to be tolacking at home. Maybe they've had 3 babies that were born preterm, so now you got to watch them for preterm delivery precautions. You could collaborate with an obstetrician and make sure you're offering them everything to reduce the risk of preterm labor, and then once they get to 36 weeks, you could independently manage them. So risk criteria has different levels. It's not just are we risking you out, but what level of risk is involved and who should be involved to take care of it, what extra screenings, what extra testings, what medications, supplements, review of education with them should we be discussing based on those risk criteria. So when you look at risk criteria, you want to look at the time frame, how long can it impact things. If they had anemia for a week, that's very different than anemia the entire pregnancy. If they had a heart murmur one time versus consistent, that's a different risk out criteria. You want to look at the nature and how severe it is. If they have asthma and it's mild and it's well controlled, that's very different than asthma where they're using a rescue inhaler and they're out of short of breath all the time and they're trying to get in with their pulmonologist to get an adjustment. They're not a well-controlled asthmatic and they shouldn't be with a midwife in the home setting. So we really want to look at their medical history, their social history, their family history, genetics, their past births, their belief system, because maybe medically they're squeaky clean, but they tell you they're not going to go to the hospital unless they're dying. To me, that's a big risk criteria because we aren't on the same page together. They aren't going to be a good, safe candidate if all of a sudden in the future we do need to go to hospital for one thing or over the other. We aren't going to be a team together, and you don't want to put that extra risk on you and your practice and serving your community long term. So these are common risk factors you want to think about and reference to when you're deciding to make them. You want to look at your local scope, standards, compliance, regulations, the service location. If you practice in the home, birth center, hospital, clinic, you work next to a doctor, employed by a doctor, you're independent in a rural community, you want to be private and confidential with their medical records. You want to make sure that you're training your staff, you're getting all the intake forms that are appropriate, you're giving them education about informed consent of resources, services, what you offer, what you practice, because you are a low risk healthy care provider. And if someone isn't low risk healthy, how are you going to determine what's the best route and what should we be doing extra and who should we be involving in the care management decision, and if they should still be a patient of ours or not. So if they're taking medication, reducing the risk of infection, abuse, environmental safety. If we have a clinic, we have a birth center, it's our obligation to make sure that we're reducing the risk for them as much as reviewing the risk for clinical care. So there's three different risk criterias out there. There's low risk criterias, and it has to do with just more day-to-day, easy to reproduce, easy to replicate, not critical, doesn't affect the day-to-day operation. There's just risk of all of a sudden the weather gets bad, the road's slippery, they're driving in, the client's a little late. I mean, what risk is happening? You don't have any near misses, you don't have any serious things. It's not the normal routine. Maybe she has a history of anemia with her other baby, but she doesn't have anemia now, so it's more of a medical history. So she's pretty low risk. She's a great candidate to be a midwife based on the medical history. It's there, but it's not anything that's going to apply to her situation. Moderate risk is like, okay, is this still a person that's a good idea to be with a midwife? Is this a good idea to be taken care of in the service level that I do? This would be someone I would consider to collaborate on. This would be someone that I would touch base with. We'd make a plan maybe every time a lab update, every time we see them in the prenatal care. We'd make a plan of care with the doctor, and as long as the plan of care is following through, we don't really have to update them again. So moderate risk just means, I can't independently take care of them as a midwife. They may still be a good candidate for a midwife and a birth center, a home, but in time, we're just going to watch them closer. We're going to do extra screenings and education and testings to make sure that they're still a good candidate for our care. High risk is when they should just be transferring. They're not, whether it's in labor or prenatally, something comes up. You find out they're having twins and you don't take care of twins at the ultrasound. You do Leopold's towards the end of pregnancy and the baby's breech and she goes into labor at that night and you don't do breech with your practice. Prolapse cord, postpartum hemorrhage, shoulder dystocia. These are high risk situations that need to be addressed quickly and promptly and get in the appropriate services, whether it's during labor and it's EMS or it's a prenatal visit. I can tell you some very high risk situations and stories I've been part of, where she comes in for a prenatal visit telling me she's had green discharge, she's 19 weeks. I do a speculum exam and I can see a bulging bag of water. I can see the cervix open. I can see a sweet little baby foot hanging out. It all of a sudden became a very high risk situation quickly. And originally we thought she just had some green discharge. She didn't make an extra appointment. She came in for a normal one. As soon as my assessment came through, I quickly shifted gears and immediately laid her down. She was put on bed rest. I called for emergency EMS. We transferred her to the local hospital that had high risk services, but your decisions of criteria can change very quickly. She could be low risk, and all of a sudden the water breaks and there's a prolapse cord. So your assessment skills are really, really important. And during high risk situations, you have to be time sensitive. You have to be the best of the best in those qualities and drills and things you practiced and have systems in place to handle those high risk situations, whether it's during labor, prenatally, they had an ultrasound come back and the radiologist calls you and tells you that this baby's incompatible with life, we need to figure out a plan with them. These ladies sometimes shift from high risk situation, and we have to address it promptly. So there's 5 steps to guide how you're going to handle a high risk situation. You're going to identify the hazard. It could be clinically, it could be in your practice, it could be chemicals, it could be weather. Depending on your practice, if you're employed, you're going to more focus on the risk factors for clinical care management. But if you're a business owner and you're the one running things, you have risk criteria not just for the midwife and clinical care, it's for every aspect of your practice. So where are the hazards? Where are the things that can increase the risk and cause harm to your patients, to the quality of your equipment, expirations, not able to open something, can't find it, they're not able to call when they need to get a hold of you because it's after hours. So you need to identify where are the problems, where are the challenges, and how do we improve them. Who's at risk when these things happen? Your patients, your family, your license, the staff you support. You need to identify and address who's at risk for the decisions that we make. If someone's low risk, medium risk, high risk, who is impacted by the decisions that are being made. Assess the risk. We already talked low, medium, high, and it could shift quickly. They're not always going to stay low. They may not always stay high. If all of a sudden you solve the problem, you had non-reassuring heart tones, they were high risk, you did your interventions, solved the problem. Now the baby's heart rate's normal and that issue hasn't occurred again. It's a gauge. It goes back and forth. They don't just stay in one or the other. I gave you the example of collaborating for a history of preterm labor. Once they get 36 weeks, they're no different than any other lady you take care of because they're now term and healthy pregnancy. So you just have to look at assess the risk factors, the timing, how time sensitive it is, what can I do about it to shift it from high risk to moderate to low risk. And some things you can do with interventions, and some things you just find out in history and good assessment skills that you have to address. So you want to consider what risk you can do, what you can do to decrease the risk. You want to consider, okay, this is a clinical care decision. We're doing that initial visit and she told me this was in her history and we need further information. So you need to further evaluate it. You need to determine with some extra testing that risk is eliminated. That isn't, for example, if they've had cystic fibrosis in the family and she's a carrier, but she doesn't know if this new partner is a carrier, you may order some genetic testing to see if the risk factor even exists for this kiddo. If they have an issue with vaginal bleeding in that first trimester, you could do an ultrasound to see if there's any concerns with the placenta and the baby's doing well. So there's certain things you can do to further assess interventions to determine how we may or may not have control sometimes of what level of risk, but we can help to mitigate more risk happening. But there are situations with education, prevention, advocacy, we can reduce the risk. We can clean out, pick up cords on the floor, have a backup generator, have regular drills with our staff. There's things you can do to reduce your risk. You want to look at further things you can do with the practice, the employees, the team. How do you balance the risk? How do we, some practices are going to determine to do vaginal birth after cesarean section in the out-of-hospital setting. What can we do? Because this puts at us, we want to offer this service to our families, but it puts us at a higher risk for liability, for bad outcomes, for reputation, where our practice isn't around anymore. So for vaginal birth after C-section, what are additional things we can do? Because we took on this gray zone that some standards say we can do in the out-of-hospital setting and some don't. What can we do as additional screenings and precautions? Maybe they see a doctor a couple times throughout the pregnancy. I had one doctor that wanted at 34 to 36 weeks an ultrasound to confirm the placenta location wasn't near the scar tissue. So there's just different layers of what some people will add and implement to do additional risk evaluation. So you want to look at further measures. How are we going to hire our staff? How are we going to train? How are we going to support our clients? What educational handouts are we going to give them? We're going to offer childbirth classes. We're going to offer baby classes, breastfeeding. We're going to do a bunch of home visits after. We're going to do further measures above and beyond the medical system to make sure we're catching things. Like, we would much rather catch and prevent things in mild depression versus now she's in full psychosis because we did the standard. The hospital sees them for 2 days in the hospital, sends them home after 6 weeks postpartum. Midwives do further measures above and beyond in that postpartum recovery process to keep a good eye on the mom and baby, especially for mental health services. So we could be doing above and beyond the local regional standards, wearing gloves, putting on extra precautions if you're in the hospital setting and COVID and negative pressure rooms. I mean, just depending on who you serve and how you serve them, you could get extra equipment. Like, I always carried extra batteries for my Doppler. Things are waterproof, like very essential pieces of equipment. I made sure I had backups that were easily available because in a home setting, you aren't at the same as a hospital where you can get another piece of equipment, or even a birth center where you can just go down the hallway and grab something. So in the home setting, your equipment bags have to have backup plans. You are able to do a few births at a time based on your volume. So some practice settings and scopes and scenarios are going to require further measures than the competitors and the other people based on how you're taken care of in the setting you're serving. So just as an overall summary, risk out criteria is a hard thing for midwives. We want so many ladies to have a home birth, a midwife, normal birth, and sometimes our biases get in play where we're like, oh, she's got hypertension, but it's well controlled. And I'm like, but did you do this screening and this screening and this screening to determine she's a good candidate for a home birth? Sometimes they don't understand all the complexity, and sometimes they just don't. They just say, well, that was in her past, it's not an issue now. Or she has this she had a 3rd-degree laceration, and what can we do to reduce that risk for her from happening again? Or medical conditions and screenings and education, we want to keep them as healthy as possible, but some people are not good candidates for midwives, not good candidates for the setting we're serving, and we have to have not just a risk assessment screening process, but also how do we get them to the best places? How do we get the testing, the labs, the ultrasounds, the consulting advice we need to help determine their risk factors in the best place for them?